Let's start with the sonographic evaluation of the shoulder. Remember the arm position that we started with. First of all, we're going to have the arm bent at 90 degrees, the palm will be facing the ceiling, and the hand resting on the thigh. We'll be taking a look at the long head of the biceps tendon, first in short axis, and then in long axis. A nice technique for location or to try to find the bicipital grooves, if you take your hand and you put your index finger on the clavicle and the acromion and put your thumb right across the anterior part of the shoulder, approximately where the thumb lies is a good place to put your transducer on the skin with the orientation marker pointing to the patient's anatomic right. And what we can see now is we come up right on top of the area of the bicipital groove. Now, it's important to start looking at the bone landmarks first. We're going to look for the medial aspect, which is on this side. This is going to be the lesser tuberosity, the bicipital groove, and the greater tuberosity was its position more laterally. Now that we've identified the bone landmarks, there's a couple important aspects of how the bone landmarks are positioned on the screen. Look at the leading edge or the most superficial edge of the lesser tuberosity and the most superficial edge of the greater tuberosity. Your goal should be to get these edges parallel with each other and as close to parallel to the surface of the transducer as possible. And let me show you the effect of when that doesn't happen. If I have the patient in too much external rotation, it is difficult to see the good, true long head of the biceps tendon in its short axis in the bicipital groove. To make adjustments for that, I simply internally rotate the hand until again I see the tuberosity's superficial aspect parallel to the surface of the transducer. If the patient is too far internally rotated, the greater tuberosity comes into view and it's difficult to get rid of the anisotropy of the biceps tendon. If I see just one of the tuberosities, I need to externally rotate so I see the two leading edge of the tuberosities as they point to the top of the screen. Once I've accomplished that, now I'm ready for movement of the transducer. I can slide the transducer superior or towards the head, and you can see the long head of the biceps tendon leaving the bicipital groove, and we lose it just a little bit. Now it is in the intra-articular portion of the shoulder. Sliding the transducer slightly inferior back to the bicipital groove, the transducer's movement is towards the elbow. Now you can see the long head of the biceps tendon in its short axis as it's sitting in the center of the bicipital groove. Once I've accomplished this position, I'm going to slide the transducer inferiorly, and now you'll notice that the biceps tendon itself has become hypoechoic or dark. That is due to anisotropy. So I need to rock my transducer by moving the core towards the ceiling or towards the floor. And once I see the biceps tendon become that hyperechoic oval again, I can now slide the transducer inferiorly, and the biceps tendon in short axis sits on the anterior part of the humerus as I slide the transducer down. Now at this point I want to improve my focus, so my focus carrots are over here on the right hand side of the screen. I'm going to adjust my focal carrots by bringing them down into my target anatomy, which sharpens the image. Now I can continue moving the transducer inferior to pick up my next soft tissue landmark, which is going to be the tendon of the pectoralis major as it comes from medial to lateral and attaches onto the humerus. At this point, where I've seen the pectoralis major, I now am at the lowest extent of the tendon of the long head of the biceps. As I move down more inferiorly now, I get into the biceps muscle itself. I will slide the transducer back up superiorly, going by the pectoralis major, adjusting for anisotropy to see the tendon, making sure that I keep the tendon centered in the middle of the screen. And you may notice a little bit of fluid on the medial aspect of the tendon at this point. That's a normal amount of physiologic fluid. And now I'm sliding the transducer a little bit more superior, adjusting for anisotropy, all the way up till I've seen the bicipital groove in its short axis. Now, I need to show an orthogonal view. So it's really nice to be able to turn the transducer with two hands. So what I'm going to do is the orientation marker is now placed to the patient's anatomic right. I'm going to use both hands and I'm going to turn the annotation marker superiorly or towards the patient's head. Once I've done that, the superior aspect or cephalid is to the left-hand side. Inferior aspect or caudate is to the right side. The biceps tendon is sitting in the bicipital groove at this point. So now I'm going to slide the transducer to my most medial bone landmark for evaluation of the long head of the biceps tendon, which is the lesser tuberosity. Once I'm on the lesser tuberosity, I can observe the anatomy which is in close proximity. We see some fibers of the subscapularis and short axis, the deltoid muscle, and the subcutaneous tissue. Sliding the transducer from the lesser tuberosity laterally to the bicipital groove, I'm going to see the nice fibrillar pattern of the biceps tendon sitting in the bicipital groove. Now, often one of the questions is posed, how do I know if I have the correct angle on the tendon to make sure I am not encountering anisotropy? There's a really nice method for doing that. The first thing I will do is I will freeze the image, bring up a measurement cursor, put it at the top of the screen, press the set button, draw the cursor down, press the set button, and now I'm going to look at the area or the angle between the leading edge of the biceps tendon and the direction of my beam. This angle should be very close, if not perfectly at 90 degrees. If that angle is at 90 degrees, then we know that anisotropy will not be the cause of the tendon becoming hypo or hyperechoic. Now, going back to live scanning, I'll give you an example of what happens to the tendon when we see anisotropy. As I slide the transducer inferiorly, we notice on this side of the screen that the biceps tendon itself has become hypoechoic compared to the tendon fibers that we saw earlier. So let's test our theory about anisotropy. So I'm going to bring up my measurement cursor once again, put it at the top of the screen, draw a line straight down all the way to the humerus, which is at the bottom here. This is the humerus at the bottom. Now, let's take a look at our angle of inclination. The beam is coming down. I have an obtuse angle here, which means my reflection is going to be poor. The fibers will not reflect directly back to the transducer. So what I have is an area of the tendon that's lost its echogenicity. We don't know if it's diseased or if it's due to angle, but one thing for sure is that the angle is not at 90 degrees, normal angle of incidence, so we have to correct for that angle of incidence before we can comment on the tendon itself. Going back to live scanning again, let's test our theory. So the biceps tendon and the humerus, this is the leading edge of the humerus, anterior edge of the humerus. Here's the biceps tendon. Now, if we heel toe the transducer down, so we're going to toe the edge of the transducer down, and we're going to watch what happens to the fibers of the biceps tendon. The fibers have now gotten bright again. So let's look at our theory of measurement. We bring the angle back down again. We're going to look at two areas. This is the direction of the beam as it comes down. It's striking the leading edge of the biceps tendon. The angle is 90 degrees to the leading edge of the tendon. So any change in the fiber brightness is more than likely due to something going on inside the tendon. A second check is that we look at the humerus distal, and again our angle of incidence is practically perpendicular, or normal angle of incidence, which means any change in the surface of the tendon is more likely due to something going on inside the tendon than it is simply angle of incidence. Now that we've taken care of our angle, we're going to straighten our beam out, and we're going to follow it all the way down the biceps tendon, all the way down till we get into the biceps muscle, or the myotendinous structure of the muscle fibers, the tendon, and the biceps muscle itself. Once we've followed it down to that point, we simply can go back up, follow the biceps tendon all the way up into the area of the bicipital groove, and slightly superior into the intra-articular portion of the biceps tendon.